Pneumocystis carne pneumonia. So this is now referred to as Pneumocystis Jiroveci pneumonia. It is a fungal infection that most commonly affects the immunocompromised, and in some cases it can be severely life-threatening. So Pneumocystis carne pneumonia. So this is referred to as Pneumocystis Jiroveci pneumonia. It is a fungal infection that commonly affects the immunocompromised, and it can be a severely life-threatening infection. And typically patients at risk, so which patients are at risk with this pneumonia? So those are having underlying disease states that alter host immunity, such as those with cancer, HIV, transplant recipients, or those taking immunosuppressive therapies and medications. So it is a Pneumocystis Jiroveci pneumonia. It is a fungal infection, and it most commonly affects the immunocompromised, and it can be severely life-threatening. So which patients are at risk? Those with altered host immunity, such as those with cancer, HIV, transplant recipients, or those taking immunosuppressive therapies and medications. It's a Pneumocystis Jiroveci pneumonia, immunocompromised, and it can be life-threatening. And patients who are at risk are cancer, HIV, and transplant recipient patients. So patients presenting with Pneumocystis pneumonia, so what are the features? They'll have this fever, cough, dyspnea, and respiratory failure. So fever, cough, dyspnea, and severe cases respiratory failure. So it is transmitted from person to person through an airborne route. So what is the mode of transmission? Means airborne route. And asymptomatic lung colonization can occur in people with normal immune systems. So even though people have normal immune system, they have this asymptomatic lung colonization, and they may also become reservoirs or asymptomatic carriers for the spread of this pneumocystis to immunocompromised individuals. So even normal people can have this Pneumocystis pneumonia, and they can spread to immunocompromised individuals. It is still the most common and serious opportunistic infection in patients with AIDS, and thanks to the widespread use of prophylaxis and antiretroviral therapy. And etiology. So pneumocystis, it was thought to be a member of the protozoan class, but it was reclassified as Ascomycetes fungus in 1988. So now it is under Ascomycetes fungus. So its life cycle had been said to resemble that of both a protozoan and a fungus. So the life cycle resembles of protozoan and fungus. Through careful phylogenetic analysis of small subunit ribosomal RNAs, so researchers have been able to compare this to plant animal, and ultimately the investigators have concluded that pneumocystis, it is a member of the fungi family. So this is a member of the fungi family based upon the cell wall composition, the structure of key enzymes, and gene sequencing. So finally it is a member of the fungi family. So it is based upon the why fungi family, cell wall composition, structure of key enzymes, and gene sequencing. So Pneumocystis genus, in that genus there are several species. So these are Pneumocystis carni and Pneumocystis jiroveci, so which infect the rats and humans respectively. Epidemiology. So this first appeared in Europe following World War II as a cause of pneumonia in premature and malnourished infants in orphanages. Okay, so it was first appeared in Europe. So not much was known about the organism at that time when it infected malnourished infants. And after the HIV epidemic during the 1980s, so studies into this illness increased significantly. And this is also known to affect patients worldwide and spread from person to person via the airborne route. So although typically seen in immunocompromised individuals, PCP, it has rarely been seen in those with functional and competent immune systems. And many risk factors were acquiring and developing. So, who are the groups at highly significant risk? Cancer, more specifically the hematological malignancies. And also the transplant patients who have undergone hematopoietic cell or solid organ transplants, and patients also undergoing treatment for inflammatory or rheumatological conditions, or patients with any condition that results in defects in cell mediated immunity. So who are the groups at high risk of developing this pneumocystis pneumonia? So these are the patients with cancer, or who have undergone hematopoietic cell or solid organ transplants, or patients undergoing treatment for inflammatory or rheumatological condition, or any condition that resulting in decreased cell mediated immunity. The most significant risk factor for contracting pneumocystis carinii in HIV uninfected patients is the use of glucocorticoids combined with immunosuppressive therapy. Supposing any patient is on glucocorticoids combined with immunosuppressive therapy, so this is the most significant risk factor for contracting pneumocystis carinii pneumonia. And one study showed that of patients with the first time pneumocystis carinii pneumonia, so 91% had used glucocorticoids within 1 month of infection. So patients who have used glucocorticoids, so within 1 month this infection will manifest. And this is commonly described in HIV infected individuals as an AIDS defining illness. So at the beginning of the HIV epidemic, rates of infection were documented as high as 20 per 100 persons, and with CD4 counts less than 200. So CD4 counts, when CD4 counts were less than 200, and the incidence rate of infections were as high as 20 per 100 persons. So the decline in pneumocystis, it began after 1989 with the introduction of primary prophylaxis and antiretroviral therapy. And although the rate of infection, this has declined significantly in the United States and other industrialized countries, so this opportunistic infection is proving to be a leading cause of significant infection in the immunocompromised individuals. This opportunistic infection, it is a leading cause of significant infection in the immunocompromised individuals. So what is the pathophysiology of this pneumocystis pneumonia? This has a predilection to infect the lung. So this infects the lung, and microscopic examination, we can see that pneumocystis attaches to type 1 alveolar epithelium. So which epithelium does it attach to? It attaches to type 1 alveolar epithelium. So because of this attachment to type 1 alveolar epithelium, so the fungus will there will be a transition from its small trophic form to the large cystic form. So this fungus goes and attaches the type 1 alveolar epithelium, and fungus transits from small trophic form to the larger cystic form. So because of this adherence to alveoli, so it is not the singular cause, but rather it is the, so because pneumocystis is going and attaching to alveoli, because this itself does not cause diffuse alveolar damage, but rather it is the host own inflammatory response. The host inflammatory response that causes significant lung injury and impaired gas exchange, leading to hypoxia and possibly respiratory failure. It is the host own inflammatory response, so that causes significant lung injury, impaired gas exchange, leading to hypoxia and respiratory failure. Pneumocystis is primarily an alveolar pathogen. It's an primarily alveolar, but in the setting of severely immunocompromised individuals, there can be a dissemination form may be seen. And extra examples of extrapulmonary manifestations may be seen in those patients who are undergoing non-systemic or second line prophylaxis. and this include hepatosplenomegaly, thyroid, ocular, ear or skin lesions. So extrapulmonary manifestations can also be seen in those patients who are undergoing non-systemic or second-line prophylaxis and include hepatosplenomegaly, thyroid, ocular, ear or skin lesions. So histopathology. It is often done on specimens to make a diagnosis of Pneumocystis Jiroveci pneumonia. So what are the stains used? Giemsa stain, crystal violet and Diffpic can be used to detect both the cyst and trophozoite. So what are the stains? Giemsa stain, crystal violet stain and Diffpic. So these stains can be used to detect the cyst and trophozoite. And the walls can be stained with toluidine blue or methenamine silver. So the walls of this Pneumocystis jiroveci stained with toluidine blue or methenamine silver. So stains like Giemsa, crystal violet, Diffpic and the walls can be stained with toluidine blue or methenamine silver. And the history and physical examination. So patients presenting with pneumocystis pneumonia may have subtle or obvious signs of illness. So they have HIV infected patients, they have a more indolent and subtle onset of symptoms. So what are the symptoms? Non-productive and dry cough. So it is a non-productive cough and it is a dry cough, low grade fever and greater than 80% and progressive dyspnea and 95% over the course of several weeks. So in contrast, those not infected with HIV patients can present similarly, but they have a more abrupt onset of symptoms and accompanying respiratory distress or failure. So in HIV patients, they will have a more indolent and subtle onset of symptoms, but in those not infected with HIV, they can also present similarly, but they have a more abrupt onset of symptoms and accompanying respiratory distress or failure. So both populations will typically have some degree of hypoxia and respiratory distress at the time of the presentation. So history must be aimed at evaluating the patient for underlying causes of immunodeficiency and the risk of contracting an opportunistic infection. So it's an AIDS defining illness and HIV infection must be obtained and whether patient is on antiretroviral therapy. History may reveal signs and symptoms such as fatigue, weight loss, myalgia, arthralgia, rash, headache, which may point to an undiagnosed and underlying HIV infection. So there might be fatigue, will be there, weight loss, myalgia, arthralgia. And also important during evaluation is to ascertain that if patient has been on glucocorticoids or had a change to that dose of immunosuppressive therapies. And physical findings are important. No classic exam findings point directly at pneumocystis, but many findings are indicative of respiratory illness such as pneumonia. So the examination will reveal crackles and bronchi, but 50% of the cases might have normal and clear lung sounds. Other findings include dyspnea, tachypnea and tachycardia, and patients will also present with fever most of the times greater than 38.1 degrees centigrade. And HIV infected patients, they often have the oral thrush as a co-infection. So we have to do a thorough head to toe examination for any other signs that indicate a underlying immunological disorder.